In neurologic Wilson disease, the treatment landscape is still centered on copper removal. The main disease-modifying therapies are chelators, especially trientine salt and penicillamine, but also we have zinc salt, which results in intestinal copper absorption. So the goal is to reduce toxic copper exposure as quickly as safely as possible while avoiding treatment-related neurologic deteriorations. So that last point is very important. In neurology, we know that some patients can present paradoxical worsening after treatment initiation, particularly if chelation is escalated too rapidly. So current practice favors a careful, individualized approach which goes with close clinical monitoring and dose adjustment based on tolerance and, of course, on neurologic response. In severe neurologic Wilson disease that continues to progress despite optimized medical therapy, we can propose liver transplantation on a case-by-case basis. That is not routine, but it's part of the evolving discussion in the field, and the 2025 European guidelines emphasize these particular options. Of course, management has also to be multidisciplinary from the start. These patients, as you know, may present with tremor, dystonia, Parkinsonism, even dysarthria, and psychiatric symptoms, or even cognitive change. So optimal care involves neurology, hepatology, rehabilitation, and often psychiatry. We also have to think about symptomatic treatment that matter as much as disease-modifying therapy, because recovery is often slow and incomplete. That means medication for movement disorders, botulinum toxin in selected cases, physiotherapy and speech therapy. And we should not forget the psychiatric dimension, because mood and behavioral symptoms are part of the disease. So concerning the unmet need, from a neurological standpoint, the biggest unmet need is clear. We can lower copper burden, but we do not know how to avoid the paradoxical worsening and still cannot reverse established brain injury. So some patients improve dramatically, but others are left with persistent motor, speech, swallowing, or psychiatric disability. So the challenge is to not only biochemical control, but it's a true neurologic recovery. That is why the field still needs better biomarkers of neurologic response, more predictive tools to identify patients at risk of deterioration, and better tolerated long-term therapies that improve tolerance and adherence. Ultimately, what we need are treatment that do more than stabilize the disease. We need treatments that restore function.